Hello, my name is Meghan Malloy, and I'm a second-year medical student at the Medical College of Wisconsin. This summer, I had the pleasure of working on a research project under the guidance of Dr. Jessica Hanley from the Department of Orthopedic Surgery at Children's Wisconsin. This project was designed to meet the need of children's orthopedic providers to determine patterns and hypothesize reasons for why no-show appointments occur in their clinics. Since Children's Wisconsin serves patients of all backgrounds and communities across our state, we were interested in determining any socioeconomic risk factors for why these patients may miss appointments. Postoperative care for pediatric orthopedic patients provides unique challenges due to both developmental and household factors. Healing of a fracture, for example, may overlap significantly with a child's musculoskeletal development, so it's imperative that these patients can make their follow-ups. However, pediatric medical care is also reliant on the abilities of patients' parents and guardians to bring them to these appointments. Previous research has also shown that no-show appointments increase incidence of poor health outcomes, all while also burdening clinic workflow and resources for patient care. Other studies have also provided evidence that the social determinants of health may be significant predictors to appointment adherence. While multiple studies have examined risk factors for no-show appointments in general and adult medicine, there is a lack of such research within the field of pediatric orthopedics. The goal of our study was to address these gaps in research and assess the hypothesis that pediatric orthopedic patients from households with risk factors correlated to low socioeconomic status are more likely to miss follow-up appointments than their more economically stable counterparts. To identify these risk factors, a retrospective chart review was conducted using EPIC. The data collected included all outpatient pediatric orthopedic visits from 2019 within the Children's Wisconsin main campus and Greenfield Clinic locations, protecting patient privacy according to our approved IRB protocol. Clinic-level data included demographics such as gender, race, and age, as well as primary diagnosis, and if a procedure was performed prior to the visit. Weekday and month of appointment, as well as time interval between scheduled appointments, was also collected. Socioeconomic parameters included insurance status, defined by commercial or public payer status. Finally, patient's home address was utilized to determine distance from clinic and a localized socioeconomic risk via the Area Deprivation Index, or the ADI. The ADI is a scale from 1 to 10 developed to serve as a proxy measure for socioeconomic status, providing the composite index of social data including income inequality, availability of resources, and infrastructure of a given neighborhood, defined by census block group. An ADI of 1 defines census areas which are considered the least disadvantaged or of the highest socioeconomic status, while 10 represents the most disadvantaged neighborhoods. The ADI data was provided by the Neighborhood Mapping Tool, a public research database developed by the University of Wisconsin. After data collection and retrospective chart review, a statistical multivariable analysis was performed with the help of the MCW Biostatistics department. This component of the project is currently underway, and results showing significant data as well as attended appointment controls will be collected in the near future. Until then, significant predictors of failed follow-up are expected to include insurance status, distance to clinic, and days between scheduling an appointment. There's also expected to be significant correlation between ADI and appointment adherence patterns, demonstrated by the pie chart in the middle. At this point, we have found that about 2/3 of all no-show appointments in 2019 occurred among patients from the top 3 most disadvantaged census block group neighborhoods, or ADIs 8 through 10. Future steps may also include qualitative studies to identify individual reasons for missed appointments. We expect this data will inform pediatric orthopedic providers of risk factors to be aware of, and to motivate future programs to meet the needs of patients from lower socioeconomic backgrounds and minimize these no-shows. This could include, for example, an increased presence of clinical social workers, transportation and childcare help, or the development of sustainable follow-up reminder systems for at-risk groups. Thank you to the Department of Orthopedic Surgery at MCW and at Children's Wisconsin for funding and supporting this project. Thank you also to Dr. Sergi Tarima and Joy Liu from the Biostatistics Department for helping conduct the analysis. Finally, we'd like to give a special thank you to the University of Wisconsin School of Medicine and Public Health for granting permission for us to utilize data on their public neighborhood mapping tool. This was an invaluable addition to our project, and we are very grateful for this partnership. Thank you again for coming to my presentation.